nice to have you here today. Thank you for coming to our second of this year's seminar on the Smarter Health Seminar, the Innovator series. We're delighted to have a speaker come to us from out west, where I think actually the weather is even nicer than it is here. We've been going through the last several months on looking at innovations in the healthcare system, particularly those innovations coming from industrial partners working with hospitals and service organizations. So we'll hear today Steve's high point vantage viewpoint of this. One small little item before we get going. Next month's seminar, 1 month exactly from now, March 19th, same place, same time, we will be having several speakers coming to us who will be looking at electronic health record solutions. These companies are from Orion, Oracle, and Hewlett-Packard. So it should be a very interesting talk. I welcome you all to come back again 1 month from now. So without any more talk from me, I'll let Dominic introduce the speakers.
Well, I've been looking forward to this opportunity for years to torture Steve to this degree. But I promised to be nice today as an unusual gift to him. I've known Steve now since the middle 1970s. Among the things that he's done over time, some of you may be a member of COACH, Canadian Organization for the Advancement of Computers in Health. This is the man that started it all, set the original organization up, and was president of the organization for 25 years. So Steve has had a big effect in Canada, creating the only long-standing Canada-wide organization that's ever existed. One of the other things that Steve did with his time, he's got his little resume here, you can read, he was a CFO, we won't hold that against him. He was also a CIO, probably did a lot of damage in that capacity, probably in another era, so it doesn't matter anymore. But one of the great things that Steve does right now is to publish Healthcare Information Management and Communications Canada, which is the only commonly read magazine in the field of health informatics in Canada. The people who are in the IS departments read it. I know quite a few people who are healthcare providers read it. In that particular journal or magazine, we have educational articles. It's had a fairly big effect, and it's one of the few regular educational documents that exists in this field. It's a great tragedy that such an advanced field has so little, but Steve has been the major contributor to that. More recently, Steve has done something quite incredible. He took a group of competing companies, and I'm sure he'll talk about this in the details, brought them together in Alberta, although it's across Canada, the company is across the entire Canadian land mass, and brought those companies together into a single organization related to information technology in the health informatics area. And that, bringing them together, has enabled them to work side by side with the Alberta government in implementing the Mazankowski report. Now, that's a very rare thing in almost any country, particularly here, where all the different vendors get together and collaborate. But what that will mean, if it's done properly, and I'm sure under Steve's guidance it will be done properly, is that we'll finally have some coordination and communication among the vendors, which is where all this technology comes from, for whom it must be profitable. So they're both the source, and we've got to keep them alive. And it should go a long way to doing that. I think CHITA, as he calls it, CHITTA, I claim with a New York accent it sounds like a cheater, but CHITA is I think a real change in the Canadian landscape, and I'm hoping companies here in Ontario will join in with them. So Steve, it's good to have you here today, bringing a little of the west east, and looking forward to your presentation.
Thank you, Dominic. The talk is called View from the Mountain. I need to explain that a little bit. This is meant to be a very, very generalized conversation between us. And what I'd like to do is sort of look at the Canadian landscape in terms of the forest, not the trees. It's a little apropos that it's from the mountains because I come from Alberta, which is very far west, and we do actually have mountains there. So first of all, I think we need to talk about what is innovation. Innovation is supposedly something new. It's a new idea, a new method. and sometimes a novelty. And I think all three of those things pertain to the health information field. So what I'd like to cover during this talk is innovation in a number of senses in regards to the healthcare agenda for Canada, which I think has become pretty well a national agenda, and many of the provinces are following it through. I'd like to discuss a little bit the barriers and the challenges, which are all very old barriers and challenges. I'd like to discuss a little bit how Canadian industry fits into that milieu, what chances, what opportunities they have. And then very, very briefly, and this is probably more of a personal perspective than anything else, I'd like to talk about some things which I find very exciting. As Dominic has pointed out, I've been in this area, I think, since about 1968, and I've been either an observer or participant in a lot of things which were innovative at the time. And after all these years, you get a little skeptical about things, but these are things which really turn my crank, and I think ought to turn yours. So we'll start with the agenda of today, and as I see it, right now the first most dominant thing is the Pan-Canadian EHR, which is very broadly connected to the Canada Health Infoway or the Information Highway. I think the second, probably most topical thing is the relevance of the physician office or the primary caregiver in participating in that EHR through the process of physician office systems. Thirdly, a very old concept, which we now refer to as patient safety and clinical decision support, which I think is again a very, very key issue on the national agenda. Fourth, and I've thrown this in because I have some very personal observations about this, and this is the personal health record as opposed to the electronic health record. And because I'm at a university, I have to talk about education as well. Now, the Pan-Canadian EHR has its genesis really way, way back to 1974. It goes back to a task force in 1991 which led to the creation of CIHI, which was probably the first articulation of the notion of health information being organized in a national sense. That was preceded by the Wilkes Report, and that was preceded by the Lalonde Report of 1974, which was the first articulation of the notion of a common health record as opposed to a series of distributed and dispersed clinical records about a patient. This is a direct quote from the Lalonde Report made in 1974. It's interesting that he speaks about great strides having been made in recent years. This was practically at the time when computers first hit the Canadian healthcare scene. These slides are available, so if you need to reference any of these things, you can get them later. So in 1997, we started to move forward with the creation of the Office of the Health Information Highway, a component of Health Canada. It still exists today, and it sort of set the tone for the notion of a national vehicle for the distribution of electronic health information. There's a number of items which they're currently responsible for. They've done a lot of work, in particular in the area of Aboriginal health and First Nations health information systems, and notably they've invested through the CHIP program in Canada. Good Lord, oh dear, I did that. How do I get back to this? Sorry. Dominic warned me, don't press the end button. Yes, I'm.
Just go forward.
Okay, the current, I'm sorry about that. If the university can have its audio problems, I can have my visual problems. Okay, right now I think the big focus is the Canada Health Info Inc., which I think is very, very dominant. Its objectives are to accelerate the development and adoption of modern systems of health information and communications technology. One of its others is to define and promote standards. Its funding currently, at the time I wrote this, was $500 million. I guess as of yesterday that was increased to 1.1 billion, right? Another 600 million I think was added. And the Kirby report has recommended that an additional $2 billion be added. The mechanism that Infoway is using, as I understand it, is to support projects which are sponsored by the public sector, who in turn partner with private industry, and I believe the distribution is about 1/3, 1/3, 1/3, and underlying it is a very, very key concept, and I think a very bold concept, that is each of the partners have some skin in the game. It is not an outright grant. The goal, as I understand it, of Infoway is that elements of an interoperable EHR, and I think that's another key word, interoperable, not a unique or a national EHR, is available across half of Canada within the next 7 years. So the key concepts that it deals with, as I understand it, is interoperability, build once, use many times, and presumably with the collaboration and participation of the provinces and regions. I know that some of their first grants, particularly in Western Canada, have to do with assisting the Western provinces in establishing a unique identifier and a provider registry. Sometimes you have to get off topic by talking about something which is not necessarily reporting the facts, but as you know, I edit a magazine, and sometimes when you read things or you get facts, you have to take the time to sit back and sort of think about things. So I've used this little term to do that. And there's a couple of thoughts to ponder. We have over time always jumped on great ideas without really sort of thinking them through. They're just so damn sexy and sound so good that we don't really examine them. And here's a couple of thoughts that I have. These are not negative things, but they're things to think about. The notion of a pan-Canadian EHR springs to mind the idea that any physician anywhere can access my record anywhere in Canada. And while in my personal circumstance, I happen to be a 2-time kidney transplant, and so for me that's a great notion. If I'm stuck here or if something happens to me here, for a physician to know exactly what my condition is, what my medications are, is extremely important to me. But when you think of it as a project or a desire, this is really the Big Bang Theory. We're moving from one element in informatics to a very, very high element in informatics. So the question that I ask is that in the way that we're looking at implementation, is perhaps the way that we're doing it, should we perhaps deal with a segment of the population which stands to benefit from a pan-Canadian EHR, which is perhaps 10% of the population, or should we consider the whole, where 90% are essentially intervention-based health records, which may have limited consequence in terms of physicians' decision-making at the current time. The second thing which I find a little confusing, these are not negative things, they're simply things which I think we should think about, is that with the creation of CIHI some years ago, one of its primary mandates through the CIHI partnership was the notion of the development of standards. And I guess we need to think about what the interrelationship between Infoway and CIHI is in this regard, because standards is a huge issue on a lot of agendas. I did it. Dominic, I'm sorry.
Oh, you did it?
Yeah.
Maybe we should change it for you.
Okay, the next editorial interlude, which you'll see very soon, deals with what is an EHR. Do any of you know? I certainly don't. Have we defined what an EHR is? And I'm going to have to stop there. No, I don't. I'm sorry. I have to back off. I guess the other thing in terms of the InfoWay opportunity is all of the provinces are very aggressively pursuing EHR strategies. Certainly Alberta is through Alberta Walnet, Ontario is through Smart Systems for Health. And I guess the question that we have to ask, or the challenge that we all have to face, is can we work collaboratively together to make InfoWay and its objectives a really golden opportunity for Canada, which I believe it is. I think it's one of the boldest ideas that I've heard of. Or are we going to look at it from the point of view of adding another level to a system, and are we adding a political agenda item? These are just things that I perhaps have thought about, and perhaps we should too. Okay. Okay. The next question is really what is the EHR? It's a debate yet to be resolved. As far as I've seen from my perspective in Alberta, currently by implication we're looking at the EHR as a unique patient or client identifier together with some demographic information. There's some encounter history, associated reports and observations, medication profile, including allergies, some lab test results in some cases. In Alberta, diagnostic imaging reports. PACS is yet a question mark because of equipment considerations, coupled with a provider registry. And frankly, this isn't, from a content perspective, not terribly innovative. Electronic patient records in a HIS environment in hospitals have looked like this since about 1972. The only thing that I've seen which is really remarkable from an Alberta perspective is the Pharmacy Information Network. The one that Alberta has right now, which is about to be rolled out, is really an end-to-end information system. Pending some legislation in terms of electronic authorization and signature, this in essence completes the loop from a prescribing physician to dispensing pharmacy, complete with addressing medication safety issues, and in a very, very cool way addresses patient privacy issues. And as I said, pending legislation is there for moving ahead. This is very uncomfortable. I'm sorry, I got lost. The Pharmacy Information Network in Alberta, in essence, means that I can sit at my physician's office. He can prescribe a medication, no online, anything that contraindicates that. He knows that if there's some contraindicating medication which another physician has prescribed, which I have not authorized him to tell my physician about, the physician knows that and has a way of dealing with that. He, in essence, then presses a button which sends a message to the pharmacy that I go to, so that by the time I leave his office, I pick up my prescription on my way home, which is, I think, a very, very cool, efficient way of handling that. Now, the next item on the agenda is the physician office, EMR. I believe it's a fundamental building block to the electronic patient record. I think the timing is very much right. Despite the lack of uptake, there's some very mature product in the Canadian marketplace which addresses both the electronic patient record components as well as the physician office management components. There are enough adequate reference sites which demonstrate that physician office systems can contribute meaningfully to the running of a physician's practice. For an example, here in Sault Ste. Marie, you got mentioned in the Romano report as a jewel of a chartless or a paperless information system. And we have the political will and funding, I believe, both here in Ontario and in Alberta. So it's a right-on-time initiative, and it's not very often that our progress in health information and the climate and the vendor community is just right. For an example, one of the big concerns that we've had is physician uptake or physician familiarity with the use of the internet and ICT technologies. There's some figures there which were published by Bill Pascal, who's the CTO of the Canadian Medical Association, together with some of his associates. It's in the latest issue of my magazine. It reveals some very interesting facts about where physicians sit. And the news is good. It's not great, but it's good. It's getting much, much better. I think there's, to sort of advocate this a little bit more, there's a relatively in-depth alignment between the vendor's product and the needs of the physician. This is a key thing. Back in the old days with hospital information systems, it was typically the vendor who thought, you're a hospital administrator, this is what you need. Because hospital administrators didn't spend any time in terms of saying, well, this is what we need. So the vendor community anticipated that. And a lot of times we got things which we really didn't want or need. In the physician office environment, there's a very close link between the vendors and the physician communities. Virtually all the vendors I know have their programs or their development based on physician user groups who, in essence, tell them what direction they want to go. The vendor community itself is not entrenched. There is no primary vendor. There are a number of actively competing vendors. The good news from a vendor point of view is that the amount of the market that is penetrated is far less than, or the potential market is greater than the penetrated market. Now that gives us a very unique opportunity which we have not had in health information systems otherwise, and that is to start, we have the opportunity in this particular market to look at the establishment of conformance standards, which I believe is essential. I think the hospital information systems uptake in this country has been without any standards whatsoever, and I think we've suffered greatly because of it, and part of the reasons we're looking at having to do a great deal in terms of establishing a pan-Canadian EHR is because of that lack of conformance. In this case, we can look at usability, we can use at functionality, we can look at technical and architectural standards, security standards, and privacy standards. And that, I believe, will eventually lead to some form of product accreditation or product conformance. Accreditation is a nasty word in the hands of some. I personally believe in it. I think that the community, the healthcare community, is really not knowledgeable to determine whether or not a vendor meets specifications. Back in the old days, we used to call that smoke and mirrors, and vaporware, and a number of other things, and I think a lot of those terms are still applicable today. Excuse me. Now, the next item on the horizon is patient safety and clinical decision support. And I really do think this is an old concept with a very new twist. The two pioneer systems that came out of the 60s, mid-60s, one which was done by Lockheed Space and Missile Corporation, which eventually wound up being the TDS system, and the work done by the laboratory compartment of Duke University Hospital in 1965, both were based on essentially decision support systems. They were both embodied order entry results reporting and direct physician-nurse interaction with the system. So this was not designed as a clerical, or they were not conceived of as clerical systems, but rather professional to computer interaction. They prompted inappropriate action, those kinds of things. I think we're just sort of catching on. Further to that, and I'm sorry for the bit of history, but I think sometimes it's great to appreciate that some of the things that we think are new are in fact old things rediscovered. And I find that in this business all the time. There truly is nothing new under this world, just a new technical way of handling it. We're faster, we're speedier, and we perhaps have more money. These are some quotes from Larry Weed back in the 70s. I had a chance to meet him in the early 70s, and I can recall a seminar in Amsterdam in the Netherlands where he was virtually booed out of the audience by physicians, because Larry himself is a physician and he started to advocate this thing. He went through some mathematical probabilities in terms of what you learned in medical school and what happened to you 40 years later in terms of balancing your own knowledge in medicine as compared to the increase of knowledge in medicine, and the math of that, if you do it, leaves you in great concern about what your physician actually knows. So I won't go deeper into that, but this in essence is the whole basis behind knowledge-based medicine and the use of knowledge systems in assisting medical practice. I believe this particular area is probably the key growth area for industry and for the technology, and because it aligns very, very closely with the concepts that we're now floating about in terms of best practice medicine, evidence-based medicine, and well, I guess not coincidentally, but it kind of shows evidence that good practice and doing things right actually saves money, because we avoid unnecessary tests that either are not timely or not relevant to the diagnosis. We reduce or eliminate medication errors, and so on and so forth. And this particularly, I think, has applicability now in the institutional environment as it has for many years. And I think once back-end integration is achieved with physician offices, we'll find that that benefit then goes to the primary care physician, which I believe is very important for both the physician and healthcare economics. Now, the one where I have some personal reservations about is the notion of the personal health record. This concept is based on the patient having full and complete knowledge of what's contained or what has been recorded in the record, and I know I'm talking absolute heresy here, but I have some real concerns. Particularly with the right to add information to your patient record and the right to quote, correct it. And I believe the way that it is articulated now, there's only very, very few exceptions under which this cannot be done. By reflection, it has no significance, is that this is probably the only area in the field of commerce. I certainly don't have the right to go to the credit bureau and look at what my credit rating is. So it's a relatively unique concept to healthcare. Reason for my editorial interlude is, and the key here is that I think the personal health record to be modified or changed has to be under professional guidance. This is not something that a patient, I can't conceive of a patient being able to go to the internet and say, oh, I think that's wrong, so I'll change it. I think I'll add this piece of history, and so on and so forth. Number one, I don't think we have the security infrastructure to handle that in the current internet environment. I have some real reservations in terms of the patient having an adequate understanding that's appropriate to interpret the information contained within his health record. And I can tell you that personally. When I was first transplanted and I wound up being on immune suppressant drugs, I wound up having diabetes, which is a common side effect. And I asked my physician, I said, Phil, well, why the hell didn't you tell me about this? Well, there's some things we don't tell patients because they will emulate it. They will fake the symptoms. Same with high blood sugar. How often have you gone to your physician and said, oh, your blood pressure's a bit up, and you ask, what is it? Well, it's just a bit up. You know, it's really hard to get, it's 180 over 120 out of them. And the reason for that is because we interpret things differently. We don't have the adequate medical knowledge. And perhaps I'm being inappropriate here, but that's a problem. Also, health records carry personal observations, which may be somewhat unflattering, which may just be little notes or reminders that a physician will put in a recorded record. If that is in an electronic format where the patient or other physicians can see it and read it, I'm not going to put those things in because I've moved from a personal observation into a recorded document which can be used legally, which may upset a patient in terms of so on and so forth. The last thing, which I have some real problems, is that if in fact, a patient makes a recording in his personal health record and a physician acts on it, and I can't imagine a physician acting on a entry in the record which is not done by another health professional. Will the patient assume the legal risk of making that change or modification? Moving right along from that wonderful controversial subject, I'd like to move into education. Education, I think, is the key motivator in education is to increase the recognition that health informatics or health is a very, very complex issue, and it requires competence. Now, I come from a time where I think when I was at Misericordia and I hired my first DP director, data processing director, I was looking for someone who could program an RPG2, and I found one, and lo and behold, once we hired someone who became the data processing director, and several years later when we moved up to the, through the IBM chain up to a 3081, he was still the data processing director, would today probably be called a CIO, with absolutely no professional training, either in healthcare or, for that matter, at that time in computer science. He had taken some courses at NAIT. And I think it is now, A, complex enough, B, important enough, and C, expensive enough that people in the healthcare system should demand competence, and in a professional sense. I happen to be an accountant. I can't practice being an accountant without someone actually saying that I'm capable of doing that, I'm competent in doing that. We're missing that in health informatics, and we need that desperately. I think on the other side of the equation, there are a lot of people who have been in this business for a long time, who have earned their stripes, as they say, and a lot of them are looking for a recognition that, yes, I've been in health informatics a long time, I do know what I'm doing, I need to get recognition for that. In the United Kingdom, for an example, there's a very strong movement afoot to look at identifying yourself as a health informatician, as a designation. And you can look that up on the website. It's quite an interesting process. Dr. Peter Murray is heading that up. On the other hand, we've also seen that universities and colleges are recognizing the need to develop curricula, and I think it's really important in this particular case because most of the universities that I've seen are actually looking at the needs of the marketplace as opposed to the needs of the university department. I think that is really a major, major turning point. Back in the old days, you almost, it was sort of like getting an accountant to work in a healthcare setting. It was terrible because you had to retrain them completely, because healthcare is very, very different in terms, even in accounting, in terms of how balance sheets look and what the importance placed on certain asset test ratios and those kinds of things, which have no applicability in healthcare at all. And healthcare does have those special needs, and it's really very gratifying to see that the universities are looking to the practical needs within the healthcare environment. And very specifically, I'm very concerned about chief information officers still in terms of people who understand the complexity of healthcare, which isn't like a bank. It's far, far more complex. It isn't like other industry. Chief privacy officers or privacy custodians or whatever nomenclature you want to attend to that. And I think in today's age, probably the most important thing, the most neglected area in our field is project management, project and implementation management. And we've got a ton of it coming down the road over the next 2 or 3 years. And the lack of adequately trained people is, in my view, very, very significant. Another key thing is that we're moving out of traditional faculties in the universities, whereas at one point in time this either would have been handled through a department of computer science because of the complexities of healthcare and informatics. In that sense, I think we're seeing much, much more where there's collaboration either between business schools and computer science, between the faculties of medicine and computer science, nursing and computer science. And in project management, I hope to see that we start to include a whole bunch of the human sciences, behavioral sciences, in terms of managing projects much more effectively than we have in the past. I think also professional or quasi-professional associations like Coach will look to having a very deep collaborative role in that to facilitate the, quote, street professionals that are out there now into this educational program to actually add some standards to the business. Here's a projection because I've seen it. This is the most fascinating piece of marketing that I've ever seen in my life, and I think it's very highly relevant. One of the great problems that we have, and which I'll allude to later, is the complete problem that we have with professional culture in healthcare. The culture under which a physician comes to practice medicine, the culture under which a nurse looks at care, neither of which have embodied or embraced in the coursework the notion of information systems. Without doing commercial, Cerner Corporation, about 2 years ago, donated or cut a deal with the University of Kansas School of Nursing, where in essence the Cerner system is used in the entire coursework of the nursing profession in that particular school. And I happen to know some people in Cerner very well. And I said, well, that's a good marketing ploy. He says, oh, you bet it is. But when you look at it as a resource for the university to actually have a live test ground, something which actually works in other facilities, irrespective of what vendor that nurse will eventually work in or that physician will eventually work in, it's the notion that an information system is part of the modality of care. It is not an add-on. And that is what we all, I'm sorry to be preaching, but that is what we all need to get a hold of. This is not something that is thrown on top of healthcare, it's part of healthcare. And I think things or ventures or innovations like this will go a long, long way to making that concept a reality. I'm probably running a little behind time, so I'll just the delivery of education. And I think this is pretty standard and straightforward. I would like to talk for one moment about virtual universities. On an international level, some of the universities that deal with informatics, and I have to tell you that Canada is probably, what would you say, 15 years, 10 years behind in terms of other countries. The Germans have had medical informatics as a PhD program since I believe the 60s, early 70s. Australia has a very advanced program. Most of the Eastern Bloc countries actually have medical informatics as part of their curriculum. Last year, the first medical informatics university was established in Innsbruck, Austria. That's all they teach is medical informatics. There's no other programs in the course. It's directly associated with the Innsbruck Medical School and also tied to a vendor of not a vendor, but an outfit which provides private hospital services within a public health system, and also in this case happens to involve Cerner Corporation. And I'm going to have to charge Doug for this. Okay, I'd like to then move on to barriers and challenges. Leadership, where we're at right now, healthcare's financial crisis, the business case, professional culture, collaboration between key players, and standards. Leadership. I think this is what it's all about. This is bottom line, top line, the whole thing. If your management, if your CEO, if your board, if your corporate structure does not support this, it won't work. It won't last the test of time. If you look around this country, the healthcare facilities that shine are the ones where the CEOs actually understand it, have always understood it, support it, the board supports it, it's part of their structure. If you don't have that, it won't work. If those leaders leave, typically you'll see a sloping going down. CEOs have to be champions of the cause. Some of you might not know, but the leadership in integrated health information systems will come from probably the most countries you would think last of. Where would you guess healthcare informatics on a national level is probably at a better, higher level than ours? Would you think Malaysia or Singapore? That's where it is. Talked with Alex Haddad a few days ago. The Kingdom or the United Arab Emirates are putting in a national system, top of the line, using all new technology. Political will. In Malaysia, guess who the innovator behind it is? The person driving it? It's the Prime Minister. The Prime Minister of the country has made this a primary political target. It's going to work. I was there. I saw several hospitals which are running full blast. And that's what we need in this country. The next piece of leadership, I guess, is that health professionals need to participate in the IT team both at a central level and diffused throughout. And what we're talking about here is that, again, this embracing of IT as part of the culture. I think we're seeing more and more physicians, for an example, take leadership roles in healthcare IT. And I think over time what we will see is that the information technology department, or the traditional IS department, will start to become almost invisible. I think it will be absorbed by the organization, and you'll see that physicians, nurses, physiotherapists, the various professionals will lead from within as opposed to leadership from without. And the role of the traditional IT department will in essence to keep the machinery flowing, and the CIO in terms of dealing with corporate strategy and interfacing with provincial strategy and regional strategy. One thing which has always been very close to my mind is the notion that we develop standards in the accreditation progress. And this is part of the leadership and corporate commitment. It's always struck me as being funny that from a hospital point of view, everybody actually gives a darn about being accredited. It's a major, major, major thing. And through that, we've achieved some standards in terms of how we conduct medical practice, how we maintain records, and so on and so forth. We've never done it for IT. And it seems to me that here we are in 2002, dealing with something which was relevant and we were capable of doing in 1968, and we haven't done it yet. We haven't done it yet. At some point in time, there's got to be an accounting in terms of saying, what are you as a hospital doing? You're not being responsible because you're not using resources which save you time and money. And I tried throwing this into the political agenda maybe 4 or 5 years ago, and someone said good luck, and I haven't had it, I'm afraid. Okay. The next barrier that I think we have, or challenge, is the state of the art. The evolution or the uptake of information communication technology in Canada, I think, has been pathetic. I think we have a terrible record. We have been almost retrogressive in this, that we should be ashamed of ourselves. And what's really strange about Canada is that probably within Canada you will see some of the world's leading institutions. I mean, we have some jewels in this country, people who shine internationally. But on the other hand, you'll see some absolute islands of poverty which are still back in the 60s. And that particular situation, I think, has put us in almost a critical environment in terms of following a national agenda, because we don't have any standard to go by. We have no, the jumping off spaces are between canyons and mountains, and this is I think a very great challenge in terms of meeting our national objectives. The other one is probably more practical and real. Excuse me, and that's healthcare financial crisis. A couple of weeks ago, it seemed to me, I read something that Canadian, or was it Ontario hospitals that were in debt to the tune of $10 billion. Is that right? $10 billion, and I think that at that time the Chrétien government had added $18 billion to the budget. I think that the numbers are about right, and last night, of course, some more. But think about it. If you're a hospital administrator, realistically, okay, even if you're an advanced hospital administrator or an advanced hospital board, politically and socially, can you really say, well, let's see, I don't have any docs because we're running out of those. I don't have enough nurses because we're running out of those. I'm $1 billion in debt. And what I'm going to do is I'm going to take 40 nurses off my floors, I'm going to take 15 physicians off my floors, and I'm going to take $800 or $80 million and I'm going to install an information system. Is that going to fly with the public? I don't think so. Like, we're between a rock and a hard place, and I think this is a major, major, major situation that we've got ourselves in. I personally can't figure a way out. You know, other than we use other funding, and I think even that is going to be subject to some criticism from the population at large. And quite frankly, I wouldn't blame the population. And my mom's waiting for cancer treatment and can't because we don't have the money or resources to treat her. But at the same time, irrespective of where the funds are coming from, we're going to install an information system, I'm sorry, but up here that ain't going to compute for me. I think that's a major problem that we have to overcome. Now, next crisis has always been the business case, and I thought I'd share this with you. A very old friend of mine is Melville Hodge, who was the team leader of the El Camino, or the Lockheed process, and this is a quote from him in 1970 or 1975 or 80, when he was interviewed. And the original deal that TDS cut with El Camino Hospital is that El Camino Hospital would pay them a fee equal to the savings generated by the system. And the cost of maintaining the system, or the profitability point, was $82,000 a month. It wasn't cheap even then. It's $1 million a year. And in 1973, according to Mel, the hospital, instead of paying him savings, paid him the fee that he was after, and consistently so. So if we could reinvent that kind of a business case where everybody came to you and said, well, here, try our hospital system. All you have to pay is what you save. We'd be jumping at it. Not the case today. Now, in that context, though, if we were to make additional investments in ICT to bring us up to par with other knowledge-based industries, we actually do need some credible evidence in terms of the real gains that we make in terms of productivity or in terms of cost avoidance. Unfortunately, we've been terrible in terms of actually documenting that in some real and credible way. Secondly, even if those opportunities or those savings lost, I don't think we've developed the methodologies in terms of the way that our system is structured to actually bring known savings down to the bottom line. You know, there's the old saying, well, you save 20 minutes per nurse per shift. What does that mean? I can't fire any nurses. All I'm doing is saving little spots of time. And we have yet to develop the methodologies where we can actually take that and reap whatever benefits there are. We have also not spent a great deal of time, and I'm talking predominantly about hospital systems here, to actually say, oh, gee, Toronto, you say you've saved X number of dollars or you've reduced your length of stay. How have you done that? Can we come and go with your team to see how we can benefit from your experiences, how we can adopt your methodologies to do this? And I do think that over time vendors will need to play a much more significant partnership role in terms of achieving benefits. So part of the product packaging of vendors is not here's the product, here's how it works, but this is how you reap the benefits that we are telling you you're going to achieve. Professional culture. I think this is still if not the predominant resistor. And as I indicated before, I think the challenge that we have is we need to somehow modify the view of IT as a modality of care, not as an add-on, topping up. I think this will change gradually as new people come into the system. Unfortunately, the resistors are old guys like me who have been practicing things for a very long time under certain conditions, and perhaps the new ones will make some change. The other alternative, which is not consistent with Canadian culture, and I'll tell you a very brief story. My physician, after the great physician purge in Alberta about 15 years ago, decided to leave, and he joined Kaiser Permanente in Portland, Oregon. And he and I, over the years, had always had some problems relative to, I was an IT person, and he was not, and I was trying to sell him on things which didn't work and had no place in medicine and so on. The traditional doctor argument, I don't need you. My way is better. And as many of you know, Kaiser is probably the most automated, if not the most automated, HMO in the United States. About 3 months after he joined, I said, "Well, John, how are you doing?" He said, "Oh, fine." I said, "So, have they got you using a computer yet?" He said, "Yeah, they do." I said, "How'd they do that, John? What inspired you?" He said, "Oh, they're real persuasive here." I said, "John, you want to work here?" And I don't think we have the gumption to do that. I think that's part of our culture, which I think in this kind of environment we maybe should look at adopting. That there's a way that we do things, that's the way you do them. Again, I'm sort of a renegade that way. Collaboration between key players, and I'm going to focus on one thing. I have to do a little pitch for Cheetah here. So I'm going to share with you, and this is all based on a single concept, that when we look at health information systems, what we tend to do from a strategic point of view in provinces and regions, we tend to look at stakeholders. And those stakeholders typically are defined as the regional health authorities, the government department, and the users. Okay? The vendor never comes into the equation. In reality, however, who actually rolls out the system? It isn't the user, it isn't the government, it's the vendor community. Okay, that's where you get your product from. And I think the story I'm about to tell you is based on that flaw in thinking, that you cannot develop strategy, articulate policy and standards for a product that doesn't exist. Because I can tell you for a certainty that HIS vendors who invest somewhere close to, $500 million in any kind of a robust hospital information system aren't going to rewrite it for you. Because there's no place in Canada that really is enough of a secure market to warrant it. So in Alberta, about 7 months ago, the government was very keen on implementing the Mazankowski report, which is in essence the provincial EHR strategy. And they decided to start with a physician office. And one of the things that they did was to create a task force, which was headed by Dennis Proddy from the University of Victoria, and included members from the Alberta Medical Association, the Regional Health Authority, the Privacy Commission, Alberta Wellness, and a team which was jointly constructed by the AMA and Wellness called the POSOP System, Physician Office Systems Program. And this thing, as all other things, had a wonderful acronym of VCUR, Vendor Conformance Usability Requirements Task Force. Cheetah, which was actually started by David Watling here in Ontario with some of my help, started talking to the government in terms of involving vendors at that level, in terms of defining user requirements, in terms of looking at technical standards, and so on and so forth. As a result of that discussion, we wound up with 2 vendor CEOs. All of our members are represented by very senior people. In physician office, typically the chief executive officer. The task force had a representative from the organization as a full voting representative. Each of the working groups had 2 vendor representatives sitting on the working groups. Are we on the same page? Oh, next slide. To actually go through a straw list of requirements in terms of EMR usability, in terms of technical and privacy issues. We held general consultation with over 40 physician office systems vendors throughout Canada, 10 of which were specific to the Alberta marketplace and actually participated in the process. We had teleconferences, face-to-face meetings between vendor CEOs as well as wellness and the POS team. Together with full vendor participation, the physician office requirements list was finalized, I believe, last week, and we'll go to the task force for approval. This is the first time, to my knowledge, where the vendor community actually was able and the concept behind it was your vendors, you're highly competitive, but we're not talking about your product or his product. We're talking about a marketplace. If we succeed in this, if we succeed in making usable standards, realistic usability requirements, okay, then people will be able to implement this system, the market will become large, and then you'll have your turn. You can kill each other in the marketplace as you choose. But the important thing here is to establish the validity of physician office systems within the physician community, i.e. you establish the market. The results of that is that process is we actually had the vendor community in concert agree to meeting the requirements that were set forth by the task force by March 31st, 2004. Together with wellness, we established the sandbox for standards conformance and uptake for the physician or for the pharmacy information systems network, lab results, back-end integration, unique personal identifier, and also in conjunction with Alberta WellNet, when they'd established their rollout team, which actually would facilitate the bringing this to fruition in terms of reality. The vendors actually not donated, but had some of their technical people seconded to this team to actually create the test environments, create the tools required to do the back-end integration. And we believe it's actually going to have a very, very positive effect in terms of how this will come out in Alberta. Since that time, Alberta is currently developing the standards for diagnostic imaging text processing. We have something like 8 vendors involved before the standard is set, not reactionary, but participating in the actual setting of the DI text standards at this time. And we think that when this is done, the system will thrive. I'm sorry? Okay, very briefly.